Welcome to Pulmonology Read Aloud's video on diagnosis of sarcoidosis, the American Thoracic Society Guidelines 2020 on sarcoidosis detection and diagnosis. My name is Dr. Anshumaneja Arora. I'm a consultant pulmonologist in India and I will be going through the read aloud of these guidelines highlighting the salient points. If you're new to my channel, then you may subscribe to this channel for regular updates and videos on pulmonology related topics. So the American Thoracic Society document for diagnosis and detection of sarcoidosis was published in April 2020, and this guideline document is basically a practice recommendation document which reviews the literature available for various aspects regarding the diagnosis of sarcoidosis. It does not deal with treatment, and treatment is dealt in the ERS document that was published in the consecutive year. Let us start with our knowledge of sarcoidosis and let's explore what we don't know and can add to our knowledge. So we all know that sarcoidosis is a chronic inflammatory disease. It affects multiple organs and tissues. It is characterized by non-caseating granulomas. It typically affects the lungs, lymph nodes, skin and eyes majorly, although most organs are affected by this. The exact cause of this disease is still unknown, and it is associated with an abnormal immune response. We know that the global health implications of sarcoidosis are still not known, but there is more and more data, and the disease is being found to be more prevalent than previously estimated. Also, the mortality with sarcoidosis is much higher than previously reported, and with more patients being diagnosed, we have more clearer picture on the disease than before. We also know that the symptoms of sarcoidosis vary based on which organ is involved, and based on the organ system, you can help diagnose this disease with better precision. The treatment involves symptom management and immunomodulation. Also, we may need to suppress the immune system, and monitoring and follow-up is as important as diagnosis because this disease can relapse and progress. So the diagnosis of sarcoidosis is classically a typical triad of compatible clinical presentation, non-necrotizing granulomatous inflammation, and you have to rule out all the other causes of granulomatous disease to be sure that this could be sarcoid. So basically, sarcoidosis is a diagnosis of exclusion. And since nobody can ever rule out all the other causes of granulomatous disease, which I will be showing in the coming slides, the diagnosis of sarcoidosis is never fully secure. So even if you are highly confident in diagnosing a patient as sarcoidosis, you just probably have a high probability of sarcoid in that case. So we must remember that whenever we label someone as sarcoidosis, we should have at least ruled out the other causes of granulomatous inflammation, and it's still not a secure diagnosis. The guidelines for sarcoidosis treatment detection have evolved. In 1999, the World Society of Granulomatous Diseases was SOG, along with ATS ERS gave a guideline in which they talked about the staging of sarcoidosis, the scadding staging. They talked about clinical radiological findings and non-caseating granulomas in biopsies as diagnostic of sarcoid. They talked about markers of activity, the ACE levels, hypercalcemia, and the BAL CD4-CD8 ratio, imaging, and the changes in sarcoid. In the ATS 2020 and the consecutive ERS 2021 guideline, which will be my next video, it was spoken about how the prevalence and mortality is increasing, certain clinical features being more diagnostic than others, recommendations on extrapulmonary screening and involvement were also given. The diagnostic algorithm changed from conventional TBNAs to EBUS. Treatment was reviewed for individual sarcoid, which could be organ threatening, and other sarcoid related issues have been settled. There's still a lot of road to go, and there is a lot of need for establishing biomarkers, genetics, pathogenesis, being able to exclude other diseases, and other pharmacological interventions. The newer guidelines started as a multidisciplinary expert panel. They also took 3 patients in their panel because they wanted to know the patient's perspective. They reviewed all the treatments, also with cutaneous cardiac neurologic in 2021 ERS guidelines. And so far, no clinical guideline or recommendation has been able to talk about all potential circumstances. So it has been again and again encouraged that these recommendations and guidelines have to be seen in context of the individual patient, the patient's values, preferences, geography, the alternate diagnosis in our region, and then only the diagnosis be confirmed. Now, the guidelines give us very clear suggestive clinical features that may be highly probable and probable of sarcoidosis. So to start with, it's to be remembered that there are certain conditions that are highly probable of sarcoidosis and which may not require a diagnostic tissue biopsy as well. These include Lofgren syndrome, lupus pernio, and as well as Hereford syndrome. Physical features of uveitis, optic neuritis along with erythema nodosum are also highly probable, and so is imaging of bilateral hilar lymph nodes, perilymphatic nodules on CT, gadolinium enhancement on MRI in case of neurologic involvement, in case of bony involvement, osteolysis, punched out cystic lesions, and increased parotid uptake in case of Hereford syndrome. Other testing, a hypercalcemia along with a suggestive clinical scenario, or hypercalciuria or abnormal vitamin D not otherwise explained, could also hint to highly probable sarcoidosis. But when we talk about a not highly probable but rather a probable diagnosis, presence of cranial nerve palsy along with parotid swelling as in Hereford syndrome, a treatment responsive renal failure which responds to management of hypercalcemia, certain cardiac heart blocks that respond to treatment, rashes, skin lesions, subcutaneous nodules, involvement of multiple organs at the same time, scleritis, retinitis, parotid enlargement, splenic enlargement, hepatomegaly, along with peribronchial thickening, infiltrates on CT chest, as well as nodes. Mediastinal nodes are highly reflective and they may suggest a probable diagnosis. Cardiac involvement is known in sarcoidosis, so you may see a lot of cardiac changes. Nephrolithiasis, calcium stones, along with hypercalciuria may also be predicted. So basically a whole conundrum of multi-system involvement with certain specific features always hints towards the diagnosis. But as the triad of diagnosis says, we can never be sure unless we rule out the other causes. So this is what the 3 most probable syndromes look like, which do not need any further testing. The first is Lofgren syndrome, which is a combination of hilar lymphadenopathy, polyarthritis, acute. Look at the ankles and you might see an inflammation, and erythema nodosum over the shins. Hereford-Waldenstrom syndrome, characterized by uveitis, parotid enlargement with 7th nerve palsy and fever, and lupus pernio, or the rashes over the malar region as well as the bridge and tip of the nose. As we said, demonstration of non-caseating granulomas is very, very important in sarcoid management. So The demonstration of typical pathological features also suggests sarcoid. So we must know as pulmonologists what are the typical features on a histopath so that we may go in favor or against sarcoid. So when we talk about granulomas, we know that these are non-caseating. So something that will favor granuloma is presence of numerous compact granulomas. Also, sometimes you may not have granulomas typical, but you may have healed granulomas. So you may have scattered multinucleate giant cells in hyalinized fibrosis. So fibrinoid necrosis kind of a picture. Sometimes you may see that these granulomas have large epithelioid histiocytes. So the granuloma morphology may be compact, tight, with epithelioid histiocytes, multinucleate giant cells, and they will stay discrete and non-necrotic, with fibrosis in the periphery. The lesions will be perilymphatic around the bronchovascular nodules, fibrous septas, and they may also show invasion of the vascular walls in case of necrotizing sarcoid angiitis. You may see lymphocytic infiltrate around it. You would typically not have AFB Zn stains positive, and you may see both intra and extrathoracic involvement. So when you compare a pulmonary sarcoid granuloma, the histology favoring a sarcoid granuloma and against a sarcoid granuloma must be known, and that way we will be able to include or exclude the diagnosis. This one shows a typical sarcoid granuloma, a well-formed granuloma you see with macrophage aggregates, and vis-a-vis this is something that may be seen in hypersensitivity pneumonitis. The granulomas are smaller. They are not as huge as these ones. They are smaller. There's less lymphocytic infiltration, right? And here we will see more lymphocytic infiltration. This is huge with lymphocytic infiltration. This is the ones with more extensive lymphocytic alveolitis and smaller granulomas. And large cellular necrotic granulomas may be caused by tuberculosis. Necrosis may also be seen in histoplasmosis and other infections. So these features can help us diagnose sarcoid granuloma better. Coming to granuloma per se, as I said, you can never be too sure, and you may not have excluded all the other types of granulomas. If you look at this list of key infectious and non-infectious granulomatous lesions given in the guideline, it is a huge list to consider. There may be so many infections, bacterial, TB being one of the most common, and especially in our country, TB being one of the most problematic differential, along with atypical mycobacterial infections that can mimic sarcoidosis. While these can still be screened with cultures, AFB demonstration, latent TB infection by means of interferon gamma testing, there may be others like fungi and viruses and parasitic infections that may be more difficult to find out, and cultures and serologic testing may be more difficult to demonstrate. We should never forget the non-infectious causes of granulomas as well, or of chronic granulomatous lesions, malignancy, lymphoma being one very important differential. Because again, presence of lymph node enlargement and granulomatous disease can also be a sign of lymphoma, but clonal cell populations may be there. You may have specific markers that you will be able to demonstrate, and in that case you may or may not, but usually you may not have lung involvement to the tune of the lymph node involvement, and so you may be able to boil down to the diagnosis. Other lymphomatoid granulomatosis, germ cell tumors, they may also present with chronic granulomatous diseases. Autoimmune diseases like ANCA-associated vasculitis, GPA, MPA, they are also associated, and rheumatoid nodules. So these all may be showing chronic granulomatous lesions. The list goes on further with other IgG4 related diseases, inflammatory bowel disease, autoimmune hepatitis, which may show granulomas, but will have other clinical pearls that can suggest that these are the primary involvement. In the lungs, hypersensitivity pneumonitis remains a very strong differential, and the exposure history, along with, as I said, smaller granulomas with more lymphocytic infiltrates around them being more typical. So the whole history of hypersensitive pneumonitis and related granulomas, obviously sarcoid we are seeing, but there may be other diseases like Kikuchi's disease with cervical lymphadenopathy, with low-grade fever, and GLUS and bronchocentric granulomas. The list continues in the form of other organ system involvements like CNS related in diseases like amyloidosis, rheumatoid nodules, and when the eyes are involved in other diseases like IBS and encephalitis, sinonasal, along with parotid, heart involvement in rheumatic or giant cell myocarditis, spleen involvement, kidney involvement as granulomatous polyangiitis, CLL, drug-related diseases, and muscle involvement. So, in multiple diseases, multiple differentials are there for sarcoidosis, and so all of them we may not be able to exclude. So, there ideally is never a confirmed diagnosis, and it's mostly a diagnosis of exclusion. With so much information, one may get overwhelmed and may forget what is the basic way of presentation of sarcoidosis in various organ systems. So we must remember that in lungs, mostly it presents in the form of cough, predominantly dry cough, dyspnea on exertion, long standing, fatigue, chest tightness, rarely in the form of hemoptysis, not very common as hemoptysis, but patient may also come to you in frank respiratory failure. Skin, we must never forget to look out for erythema nodosum, and I said other signs like lupus pernio, subcutaneous nodules and palpation, they may be good signs to elicit. Eyes, look out for interior uveitis, conjunctivitis, optic neuritis on retinal examination, and in the heart, we may have patient coming with heart blocks, arrhythmias, heart failure, or pericardial effusion. So now let's come to this diagnostic algorithm which is given in the ATS 2020 guidelines. One thing that I want to highlight before starting reading this algorithm is that if you notice, then no matter what you do to diagnose your disease, you may still have a probable sarcoidosis. So even if you are very confident on your diagnosis of sarcoid, the diagnosis is usually most probably sarcoidosis, and this is important to remember because it tells us how important it is to exclude other diseases, and sarcoidosis can almost never ever be empirically diagnosed unless you rule out the other factors. However, there are a few classical presentations, as we mentioned, Lofgren, lupus pernio, Heath syndrome, where we may be suggestive of highly probable diagnosis, and if you do not have any other site where you can biopsy, you can go ahead and consider this as a diagnosis and keep the patient on follow-up. We'll talk about this in the questions that were proposed by the committee. But if patient has bilateral hilar adenopathy, if you can go ahead and do a lymph node aspiration or a biopsy, then that should definitely be considered, and we'll have a probable sarcoid as our diagnosis. If your patient has features consistent of sarcoid, or you are suspecting sarcoidosis, or features are probable or highly probable for sarcoid, you must consider if biopsy is recommended. Again, we'll be talking about the questions that they subjected wherein biopsy may or may not be done. But if biopsy is recommended, if biopsy is possible, and you do perform the biopsy, then in case your biopsy is negative, and your sampling is negative, but clinically you thought that this patient does fit into sarcoidosis, then also you may consider him as a probable sarcoid. In case the clinical presentation is not supportive, the biopsy is not supportive, then definitely you must consider alternative diagnosis. Now, in case this biopsy was performed, it was not consistent with sarcoidosis, clinically also it may not favor, then you consider other diagnosis. But if you feel that it is still a probability, you still support sarcoidosis, you may go down the path of trying to prove it with other tests. Now, if you did a biopsy which is positive, which is consistent, you've ruled out other causes of granuloma, then it is a probable sarcoid, and you may go on and do the other treatment modalities for this patient. So quite clear, and basically it all says that you must have a very good clinical suspicion, you must have a consistent biopsy in case you're performing one, and you must exclude other granulomas. Now, this is not a part of the guideline, but generally something that has been taught over and over again. We'll be talking about the treatment of sarcoidosis, the guidelines of ERS 2021 in my next video. But it's important to note that a lot of patients of sarcoidosis, especially the ones who are asymptomatic and do not have any organ system involvement, will not require any treatment. Treatment may be in the form of steroids, immunosuppressants, and sometimes biologicals. And this is mostly given to patients who have significant organ involvement, or patients who are on steroids and we have to taper off steroids, we may give immunosuppressants. So organ involvement is something that really predicts how we are going to manage our sarcoid patient. One very good table that the guideline gives us is one of follow-up testing, and this is very important because once you diagnose the patient, there are high chances of relapse after stopping the immunosuppression. So one of the tests that is very recommended is serum calcium levels. It's recommended that you should do serum calcium levels every year, and if patient develops kidney stones or patient develops a new onset renal failure, you must look at it more closely, and you may need a liaison with your nephrologist there. Also, annual creatinine levels must be done in your patients. To rule out hepatic issues, you must do an annual alkaline phosphatase. Eye examination is not recommended as a follow-up routinely, but there are certain soft indicators like a change in vision, presence of congestion in the eye, floaters, blurry vision, or eye pain, eye redness that is not going. So in such cases, you would want an eye examination. It may be a good practice to do it on a regular basis, but obviously guidelines can only give certain directions, and they may not be verbatim followed. So you may do it more frequently, you may do it annually for your patient, but for the guidelines purpose, there are certain indications where you would want to repeat it. Cardiac testing, again, routine testing for new sarcoidosis involvement. You may not do an extensive cardiac testing, but again, soft indicators are patients with pain, palpitation, syncope, heart rhythm changes, a dyspnea which is still persisting on treatment. Maybe you would want to rule out pulmonary hypertension developing. So in such patients, you may want to keep this follow-up. And pulmonary hypertension testing, again, initially if the patient did not have pulmonary hypertension and he now shows signs of pulmonary hypertension, you may want to repeat it. Coming to certain questions that were proposed by the guideline committee, and these are last 6 slides of this video, and we'll be talking about what recommendations they give for particular conditions. Remember, all of these are conditional recommendations. They have very low evidence, and there is only one major recommendation. The rest are just practice principles that have been suggested. There may be scenarios where you may have to do something against this. So in the sense that you may actually go for the other modality of investigation, or you may want to follow up your patient with a particular marker, even though the guideline doesn't recommend it, which is totally fine because the level of evidence for this is not very strong. But these are good practice recommendations that can be considered. Number 1, as I said repeatedly in this video, if you have a high clinical suspicion in one of these 3 syndromes, you may not do a lymph node sampling. But in case you do not do a lymph node sampling, you might make sure that you follow up this patient and see this patient is not worsening and not showing signs of other organ involvement. Patient with asymptomatic bilateral hilar lymphadenopathy, again this patient would follow in a group where you may not do lymph node sampling, but you may want to closely follow up. Almost 60% of patients who have asymptomatic bilateral hilar lymph node will have a resolution of or spontaneous resolution of these lymph nodes in 60%, but you may want to closely follow up your patients even if you don't do a regular sampling in all of them. However, if a patient is suspected to have sarcoid, he does not have symptoms, but you feel that he merits sampling, whenever you want to sample lymph nodes, EBUS or endobronchial ultrasound guided sampling of the mediastinal lymph nodes should always be recommended and preferred over mediastinoscopy. And this comes after reviewing a lot of systematic reviews which compared EBUS and mediastinoscopy. And though mediastinoscopy still has a higher diagnostic yield of the tune of 98% as compared to EBUS, which has 87% diagnostic yield in most systematic reviews, but EBUS is simpler, more easily available, with lesser serious side effects, and there may be an underestimation of the risk of mediastinoscopy in the literature. So EBUS definitely gives us very good quality sampling data. Also, EBUS can easily be combined with transbronchial biopsy, endobronchial biopsy, so that makes it more easier for us to interpret everything in a whole. So EBUS definitely is in favor of lymph node sampling. Coming to the screening of extrapulmonary diseases, here three most important systems have been taken into consideration: the eye, the kidney, and the liver. So amongst the eye, a lot of patients with sarcoid may not have any symptoms related to eye at presentation, but the burden of ocular disease in sarcoidosis is almost 26%, and it can go as high as 50% in certain populations, like in the Japanese population. So eye examination is something which does not cause any burden. It's not harmful, it's very easy, and vision is so precious to our patients that the committee recommends that all patients should undergo a baseline eye examination. And this also helps because it may help us guide our treatment. Suppose if a patient has glaucoma, we may not want to give him steroids for a longer time. We may want to look out for HCQ related retinopathy. So all of these can also be managed better if we have an eye examination in place. So that's really important. Number two, kidney. Kidney involvement is also very, very significant in sarcoid. In fact, renal failure is one of the most dreaded complications of or co-occurrences of sarcoidosis, and so a baseline serum creatinine is something that can be easily performed in almost all scenarios. Now you must remember that sarcoidosis can cause compromised kidney function in two ways, and these two ways is one either in the form of glomerulonephritis or the other is in the form of interstitial nephritis. Now this can happen secondary. The glomerulonephritis or the parenchymal involvement is one thing, but the second can happen as a consequence to altered calcium metabolism. So because of nephrocalcinosis or nephrolithiasis. So it's very important to act in time for renal involvement in sarcoidosis, because that can cause a progressive renal dysfunction, and it is very well responsive to treatment. So immunosuppression can actually attenuate and reverse back sarcoidosis induced renal complications, but in case we do not, then it's progressive, it's persistent, and the clinical outcome is poor. So something like a serum creatinine is not harmful. Most patients will do it, so it's important to go ahead and do it. The other thing is that in case kidney involvement is there in certain scenarios, we may have to continue immunosuppression and we may not be able to bring it down. So in that case, again, this really helps. But the question here is that is creatinine sufficient to help us monitor the kidney? And this is something that the guideline has looked into, and although creatinine has been mentioned because it's easier, but the committee has acknowledged that there is an uncertainty if there could be a better marker. Could we be doing urinary creatinine instead? Should we be doing 24-hour urinary collection and 24-hour urinary creatinine? So all these are still matters which are for research. They are more costly, more difficult. So in a guideline setting may not be recommended, but if your patient has a borderline deranged creatinine, your nephrologist may recommend you to go ahead with the urinary creatinine and other tests to screen for renal dysfunctions. There may also be certain patients where something like a renal biopsy may be required, and because that will help us not only establish renal sarcoidosis, but it will also be of importance to predict what kind of immunosuppression the patient will need and whether we'll be able to de-escalate it. So a lot of matters of sarcoidosis involve the kidney. So baseline creatinine is definitely to be done, and I would say if it's even mildly disturbed, we must involve a nephrologist in our MDT, and we must take care of that. The third organ to be seriously involved is the liver. So if your patient does not have any symptoms of hepatic sarcoidosis, then also a baseline serum transaminase is recommended. However, the guideline also say that it can neither support nor refute routine serum transaminases at baseline, but it should be performed as a good practice. And this is important because almost 12% of patients with sarcoidosis will have an abnormal liver profile, and although all of them may not require any particular attention, and some increase in alkaline phosphatase and serum transaminases may be there, but alkaline phosphatase has also come out in a way to be a good predictor of hepatic involvement. So although baseline serum transaminases can be done, alkaline phosphatase can also be added. And it has been seen that, again, just like kidney, these improve with treatment. They improve with ursodeoxycholic acid. So it may not be really something to be worried about, but it's important to have it known at the baseline. So again, these should be done. The other three variables that have to be mentioned here include one of calcium levels, and this is the only recommendation, the only strong recommendation that comes out of screening for extrapulmonary diseases. So even if the patient does not have any symptoms and signs of hypercalcemia, you must always do a baseline serum calcium testing, which is very important because abnormal calcium metabolism will not only lead to hypercalcemia, hypercalciuria, kidney stones, and renal failure. It is also the most common cause of sarcoidosis related renal insufficiency. So calcium metabolism dysfunction will result in kidney failure, and it will also result in more bone resorption, increased renal absorption of calcium, and out of 6% of patients who may have a baseline hypercalcemia, almost half of the patients will end up having renal failure. So this entity, hypercalcemia, is important to screen, and the good thing is that in more than 90% of patients, just with immunosuppression, just with addition of prednisolone, this resolves with good hydration, but then this must be checked. With calcium comes vitamin D. The metabolism is interrelated, and so the guidelines say that although you may not do vitamin D levels for everyone, but if you feel that vitamin D testing is needed for this patient, then you must do both 25 and 125 hydroxy vitamin D and then replace it. And the data with 125 hydroxy vitamin D has not been extensively studied with systematic reviews, but there are so many reasons why 125 hydroxy vitamin D testing must be done in sarcoidosis, and one of it is that it's been postulated that 125 hydroxy vitamin D may be a biomarker of the granuloma. So that may tell us how active the granulomatous disease is. So vitamin D levels must be checked. If you suspect there may be a deficiency, there may be a subset of patients like patients with fatigue, patients who are on steroids, where you may want to give vitamin D, and then you may check in. The third factor here is CBC or baseline CBC, a test which looks almost non-troublesome. We do a baseline CBC for most patients, but although it is recommended to be done as a screening test, we must know why. And the reason is that there may be a lot of hematological abnormalities. There may be leukopenia, there may be lymphopenia, there may be thrombocytopenia, there may be pancytopenia because of bone marrow suppression due to sarcoidosis. Also, spleen is an organ that's highly involved, so splenomegaly can also cause hepatological manifestations. There could be anemia, there could be other manifestations. So and spleen also, if there's no splenomegaly, then also there may be a white blood cell compartmentalization in the involved organ, again causing leukopenia and lymphopenia. So you must look out for these hematological abnormalities, and although they are very transient, but they must be screened. Coming to the last two factors of extrapulmonary disease, one is the cardiac system and the pulmonary hypertension. So cardiac sarcoidosis is something which is very important. We must make sure that we ask our patients about symptoms related to cardiac sarcoidosis, and if your patient does not have any cardiac symptoms, he does not have signs of cardiac sarcoidosis, you must still do a baseline ECG screening, and this is the minimum. So they do recommend that you must do a baseline ECG screening, but they do not recommend to just go ahead and do a ambulatory Holter or a routine echo if your patient has extra cardiac sarcoid with no cardiac symptoms. However, if you do feel there's an involvement of cardiac system, which may be in the form of palpitations, which may be in the form of arrhythmias, in the form of change in heart rate, then if you do suspect there's a cardiac involvement, you must go ahead and do a cardiac MRI, which is very important, instead of going for a PET scan or a echo, a transthoracic echo. And regardless of the test's inability or ability in case of ECG to test for cardiac sarcoid, ECG gives us a very good clue about a risk of cardiac events. So this readily available, non-invasive, harmless test should be done at baseline for most patients, right? And doing a transthoracic echo Holter at the screening may not be helpful if you have no symptoms. So in such cases, you may not want to do it. Again, we must ask our patients about palpitation, about lightheadedness, about chest pain, about syncope, because that increases the likelihood of cardiac sarcoid. The other factor is suspected pulmonary hypertension, and sarcoidosis is also a cause of pulmonary hypertension. So in patients where you suspect it, you may initially test with transthoracic echo, and once you've done that, you feel this patient has suspected PH and echo is suggestive of pulmonary hypertension, then you must do a right heart catheterization for confirmation. The evidence is low, but it is an important factor, because if you know that you're suspecting pulmonary hypertension, a right heart catheterization will help us determine what is the treatment to be followed up next. When do we suspect? What are the symptoms that suggest PH? They are usually fatigue, syncope, chest pain, on examination loud P2, a reduced 6-minute walk, more desaturation as compared to the lung involvement, a reduction in DLCO, or on a CT scan you may see pulmonary enlargement. If you suspected pulmonary hypertension clinically but echo was not suggestive of pulmonary hypertension, on case-to-case basis you may or may not go ahead with right heart catheter. So this a clinician has to best decide. So we briefly understood what are the diagnostic implications in sarcoidosis. We've understood that we have to exclude other diseases. We've understood that it is a diagnosis of exclusion, but what is the treatment? So we'll be discussing about the treatment in the part 2 of this series. The treatment is from the European Respiratory Journal 2021 treatment guideline. So I'll see you over in the next video. Till then, happy reading, keep sharing and subscribing. Bye bye.